Chapter 14 talks about high-risk postpartum care. So I'll be going over most of this chapter. These are the objectives. So the biggest thing about this chapter are postpartum infections and postpartum hemorrhage. Postpartum hemorrhage. So they classify hemorrhage as primary, early, or secondary, late. Remember, a hemorrhage can happen early postpartum, or it can happen, sometime after. But it is described as a blood loss greater than 500 mLs for vaginal deliveries and 1,000 mLs for cesarean deliveries, with a 10% drop in hemoglobin or hematocrit. The usual causes for primary postpartum hemorrhage are uterine atony and placental fragments that are retained and genital tract lacerations from the inside, of the birth canal. There are some critical components that you really should pay attention to here that are helpful. They're kind of quick go-to parts in your book. So I would definitely read those. Postpartum hemorrhage, again, classified into early or late. Usually the early postpartum hemorrhage occurs within the first 24 hours after childbirth, usually due to atony or lacerations, hematomas, and the secondary occurs after 24 hours post-birth, and again is due to hematomas, subinvolution, or a lack of, the uterus returning to its normal state, or retained placental tissue. Risk factors for postpartum hemorrhage are neonatal macrosomia, or a birth greater than 4,000 grams, big baby, polyhydramnios, multiple parity, prior postpartum hemorrhage, and operative vaginal delivery, like we talked about, using forceps or using the vacuum extractor. And then augmented or induced labor. So we induce labor, and that can cause greater contractions, causing a little bit more precipitative birth, or forceful contractions causing more forceful, descent. So there's quite a list in your book there as well. You can take a look at those. So uterine atony, this is a decreased tone in the uterus muscle, and it's the major cause of hemorrhage, postpartum hemorrhage. So uterine contractions constrict the vessels at the placental site and can decrease the amount of blood loss. So when their uterus is relaxed, the vessels are less constricted, and the woman will experience an increase in blood loss. So that's really the definition of uterine atony. Findings will be when we assess the woman to find uterine atony. That is, again, we talked about this previously, but that soft, boggy fundus, and the contractions are not clamping down on that uterus, and it's becoming boggy. You'll have saturation of peripads frequently, every 15 minutes or more often. Bleeding can be slow, but it's steady and sometimes massive, and you'll see blood clots at times. The woman become somewhat, shocky, where she has, pallor and clammy skin, anxiety, confusion, tachycardia, and hypotension. So again, this can be put the woman in a risk of going into shock. Some of the factors leading to atony, overextension of that uterine musculature, multiple pregnancies, 2 or more fetuses, hydramnios, excessive amniotic fluid, and the uterus is just exhausted. And that can also be from too much Pitocin or augmentation of the labor. And Oops, sorry about that. And again, monitoring for signs of shock is going to be a critical nursing assessment or nursing action. Also, in the previous slide, for the atony, the uterus has to be massaged. We can even do bimanual compression um, and IV therapy to reduce the risk of hypovolemia. There's again some other stuff in your textbook that I just didn't mention. For this one, lacerations. Lacerations can be deceiving. Sometimes people think that, oh, it's just a laceration, stitch it up and it's fine. But sometimes these can bleed. These are common sites are in the vaginal wall, the cervix, the lower uterine segment, or the perineum. Um, Depends on the degree of the laceration itself. So there's first degree tears of the vaginal and perineal membranes. There's also second degree tears and third degree, fourth degree. So we can have quite challenging tears that we try to suture up, but sometimes these still bleed. So they're at risk for bleeding in there. Some of those causes, again, are the use of forceps, the use of extraction, precipitous labor. When we do our assessment, we might find a firm uterus, more than normal, heavier than normal bleeding, and steady stream, sometimes with clots. Women can have tachycardia and hypotension. So again, it's good to be monitoring those vital signs. Large baby is another cause of these lacerations. Pretty much very similar from what we talked about with atony. So hematomas, these can occur when the blood pools and forms a hematoma under the skin around the vagina or perineal area. Vessels that have ruptured and bled into the skin. There's a good picture on page 360. Some of the risk factors are episiotomy, that's the biggest one. Use of forceps and prolonged second stage of labor. Women do find it very uncomfortable and painful to have a hematoma. Again, they can have presence of tachycardia and hypotension. There can be lots of swelling, discoloration, and tenderness, and they can hold as much as 200 to 500 mLs of blood, and not large enough to cause uterine atony. It increases the possibility for large amounts of blood loss as well. Smaller hematomas, we kind of monitor them. They don't get surgically. No, we really don't do anything. Large ones can be excised surgically and the blood evacuated, but monitoring them, putting ice, heat, usually ice, pain medication, making sure that they're not bleeding, and monitoring their H&H as well as their vital signs is pretty important. So hemorrhage and caused by subinvolution. Again, this is when the uterus does not go back to its normal size or even start to move back to its normal size, does not descend into the pelvis, usually occurs later in the postpartum period. Uterus and lochia they originally start to go into normal involution, but then for whatever reason stop and go into subinvolution. So risk factors are fibroids, uterine fibroids, metritis or infection of the uterus, retained placental tissue, and then assessment findings. Again, you're going to find a soft and larger than normal uterus for the days postpartum. It should not be that big and soft. And then Lochia returns to the rubrous stage and becomes heavy, and often these women also have back pain. We can do an ultrasound and take a look at the uterine tissue to see whether it's placental tissue, retained placental tissue, or what the cause is. And depending on the cause, if there's retained tissue, we're going to do a DNC to remove it. If it's fibroids, we can do methergine, just PO methergine. And if it's metritis, we're going to do antibiotics. So again, depending on the cause, and then of course treatment will follow with the cause. I kind of mentioned placental, retained placental tissue. Sometimes this occurs if some of that placenta had remained inside the uterus after childbirth, and usually we can tell if some of it has retained, but sometimes a little bit stays in there and a little bit can cause some problems. But there are 3 types of retained placenta. Trapped placenta, where the placenta detaches from the uterus and becomes trapped through the cervix closing. Partial accreta, where the placenta grows into and becomes attached to the uterus. And placenta adherens, the muscular layer of the uterus fails to contract. But there could be a variety of reasons. Uterine contractions are what cause the placenta to detach and ultimately become expelled. But if the uterus doesn't contract well, then you have weak contractions that are not getting that placenta to be expelled like it normally would be. Assessment findings are going to be profuse bleeding suddenly after the first week postpartum. And then, of course, subinvolution of the uterus. Temperature can go up, and uterine tenderness if it develops into metritis, which is basically an infection. Pallor, tachycardia, and hypotension can also be found. So the medical management for this is a DNC to remove that placental tissue, and then they will give antibiotics to prevent or, reduce the risk of metritis. So this slide, coagulation disorders, talks about DIC, and we've talked a little bit about this, but this is a nice section in your textbook in this chapter. I know some of these things are redundant, but it is good to read them over and over again, and then they eventually stick in your head, and that's what I've found for students. It's very helpful. So DIC, also known as disseminated intravascular coagulation, is when it's usually caused by some kind of severe illness. Sepsis is a cause, trauma is a cause, obstetrical complications, malignancies. But really what's happening is the coagulation pathway has been hyperstimulated. In other words, the coagulation pathway, once it starts like this in DIC, it just keeps going. So the women, their body is breaking down clots faster than they can form them. So basically they're using up all of their clotting factors, and they bleed more. They can bleed from all kinds of sites, actually. And one of the biggest risk factors is postpartum. Women can go into DIC. There are some more risk factors that could be potentiated. Abruptio placenta, HELP syndrome, amniotic fluid embolism. These are a couple of the bigger ones. The primary cause of DIC is abruptio placenta. So just remember that if there's a test question. Assessment findings, a lot of bleeding, uncontrolled bleeding, bleeding from all kinds of sites. Like I said, IV site, incision site, gums, bladder, pretty much any orifice that could bleed potentially will bleed. We have to get this woman to the ICU and start giving her platelets, monitoring her clotting factors, trying to help with her anxiety, because the women will have extreme anxiety. They'll go into like shock syndrome. And so again, we want to replace those platelets so she can return to normal. And sometimes it's replacing blood and platelets. But this is considered a medical emergency. Um, we can also try to reduce the risk of potential DIC in some of our women by planning a little bit ahead. If a patient has complications of abruptio placenta, we can, be sure that we're looking for DIC earlier, and having a large bore IV site, having IV fluids available, oxygen available, and that kind of stuff. So, a amniotic fluid embolism is another coagulation. Well, they grouped it into coagulation disorder. And that's because it's very rare, but it is a complication where the amniotic fluid is like an embolism, a fluid embolism, and it travels somehow gets into the mother's um, circulatory system, and it can also potentiate a DIC as well. So the fluid enters into the maternal vascular system, but we really don't know how, and it causes an embolism. So it could, same thing as any kind of embolism. It can go to the brain, it could go to the heart. So we do want to monitor both, um, and this again could be a serious condition where the woman is jeopardized and her life is at risk. Many of the risk factors include induction of labor, abruptio placenta, placenta previa, post. Let's see. No, I'm sorry. Um, but the research is that we don't have one specific thing that we say is the ultimate cause. Assessment findings, you're going to find shortness of breath, seizures, hypotension, cyanosis, cardiopulmonary arrest, uterine atony that causes massive hemorrhage and leads to DIC, cardiac and respiratory arrest. So there's multiple things that you could see in these women. Medical management, there's no scientific data that tells us this is the intervention, but of course we're going to focus on the ABCs, breathing, respiratory, cardiac. We're going to stop her hemorrhage. We're going to do lots of blood work to monitor. Oh, there's ants over here. And then make sure we do a type and screen because this woman may need blood transfusions. There is a little table, 14-1, that talks about stage 1 and stage 2 of an amniotic fluid embolism. So the stage 1 is when the fluid and fetal cells enter the maternal circulation and release endogenous mediators, causing a pulmonary vasospasm, pulmonary hypotension, and it's just like a cycle of things that happen. And then stage 2 will be hemorrhage and DIC. We do need to do a chest X-ray to confirm blood replacement, and the woman needs to go to the ICU or the critical care. So this one is not as rare, but it certainly is an unexpected when it happens, and we certainly don't hope for this. Thrombosis, the blood clot, thrombophlebitis, anywhere a woman can have pooling of blood in a vein, and then this clot, can be released. So we're worried about this. DVT is another name for it. Major concern is that the clot will detach and become an embolism and travel to a vital organ like the lungs or the heart or the brain. So again, risk factors: coagulation disorders, any cesarean birth, metritis, decreased mobility where the woman's just not able to move around, especially if she has had complications of childbirth. Obesity. Assessment findings will be tenderness and heat over the affected area. Leg pain with walking, swelling in the infected leg. One leg will be bigger than the other. We can confirm it by ultrasound, Doppler ultrasound. Coagulation therapy will be initiated right away. That's part of our medical management. We're going to give IV heparin and then bridge over to warfarin. Antibiotic therapy if we think there's a possibility that it was caused by an infection. And then put the woman on bed rest with the affected leg elevated. We don't want that clot to be released, so we put them on bed rest. I think we want to try to prevent it, of course, before it happens. So if there's reasons why women need to stay in bed, we can use TED stockings or SCDs on their legs, anything we can do to try to prevent the DVTs or the thrombosis. Okay, metritis is not that uncommon either because it's unexpected and we certainly don't want it to happen, unintended. It's the most common postpartum infection, according to your book. It's an infection of the endometrium, myometrium, or parametrial tissue that usually starts at the placental site and spreads to encompass the entire endometrium. 2% of women who experience a vaginal birth and 15% who experience a cesarean will develop metritis. Risk factors: cesarean birth, with a primary risk factor, prolonged rupture of membranes, prolonged labor, meconium stained fluid, internal fetal and uterine monitoring, multiple cervical exams, so we don't recommend those either, obesity. So the assessment findings will be elevated temperature, greater than 38, with or without chills, abdominal pain, uterine tenderness, subinvolution, tachycardia, malaise, all the things that you would get with sort of an infection. Lochia is heavy and foul smelling, so that's another unique factor, is that their lochia is going to be foul smelling. If it's streptococcus beta hemolytic strep, the lochia is scant and odorless, so not always knowing, but the temperature and the chills are certainly a malaise and the kind of feeling that you're feeling awful. Medical management, we're going to do some labs, the CBC. We want to look at the white blood cell count because remember, you're going to need to know some of these lab values like red blood cells, white blood cell counts. If it's greater than 20,000 millimeters, then that's a lot. So we don't want them to be high like that. So we'll do some blood cultures, and then we're going to use antibiotics. The blood cultures are important because we want to have the appropriate antibiotic in place. So we'll start them on something, we'll see what grows from the culture, and then we'll change it as needed. Try to reduce the risks of metritis by educating the woman on proper hand washing techniques, proper pericare, early ambulation, encourage intake of fluids to rehydrate, monitor for signs and symptoms of metritis. So if you see a woman's developing any kind of signs and symptoms of infection, you want to report that right away. Another a complication postpartum is infections like cystitis, which is, of course, infection of the bladder. It is common for this to happen in the postpartum period. It is easily treated, but of course, it can put them at risk for pyelonephritis if they don't get treated early enough. Risk factors for cystitis are epidurals. They decrease the woman's ability to feel the urge to void, over-distended bladder, because they have incomplete emptying of the bladder, Foley catheters that are inserted during labor, macrosomic babies or neonates, operative deliveries like forceps, vacuum extractor, vaginal exams. These all can cause cystitis as well as other things like metritis. Again, assessment findings: fever, burning on urination, suprapubic pain, urgency to void. These are all symptoms. Small voidings and more frequent voidings. We're going to do some tests. We're going to do a UA, a CBC, urine culture and sensitivity, and then put the woman on antibiotics, making sure we get them started on antibiotics and then wait for those cultures that take 3 days. And then there's a lot of nursing actions you can review in your book to, help the woman with reducing risk of cystitis. Mastitis. This one is infection or inflammation of the breast tissue. Very common to happen with women who are lactating and they're breastfeeding, and sometimes the milk, just has a blocked milk duct, and they, end up with this swelling. It also can happen with cracked or sore nipples. They'll have hard, tender, palpable mass on their breast, and it'll be red, and usually like a big mass of redness. And it's hard, and it's painful, and they have a temperature elevation, sometimes tachycardia, malaise, and purulent drainage can even happen. So they'll do a culture, and they'll take a culture of the expressed milk, they'll put them on oral antibiotics for 10 to 14 days, and then they'll check that, of course, in the meantime, checking that culture. A lot of teaching you can do for risk reduction about proper hand washing, because they don't want to spread bacteria to the breast, decreased nipple tissue irritation. We don't want little nicks in the tissue around, so breakdown of the tissue, cracks in the nipples is important for them to prevent, because that opens up an area for infection. You can assess for mastitis yourself. And nurses can do that, but of course we would refer them to their midwife or their provider, their physician, and they're going to order antibiotics and analgesics. They can put warm compresses. They can continue to breastfeed on that side, by the way, or they can hand express if it's too painful for them, and it's very common. All right, wound infections, of course, any wound has a potential for infection at any point, any wound, including episiotomies, cesarean sites, any laceration site. So risk factors, especially diabetes, that's a big one because they have poor wound healing anyway, so wound infection kind of makes sense. But other things for risk factors are malnutrition, obesity, a prolonged labor, premature rupture of membranes, pre-existing infections, immunodeficiency disorders, anything that reduces their immune function, steroid therapy, and poor suturing technique are some of the causes. So you'll see erythema, redness, heat, swelling, the typical stuff, drainage, increased pain, and we're going to obtain a culture of the wound, and then we're going to put them on antibiotics. They'll be on orals. Warm compresses will help. And if it's a bad enough infection, severe infection, they'll put them on IV antibiotics, especially if it's a diabetic. Usually they do that. So you'll hear some of this stuff again and again, like I told you. Postpartum depression, we did talk about it a little bit already. It is considered a mood disorder characterized by severe depression occurring within the first 6 to 12 months postpartum. It is classified as a major depressive disorder when the woman has a depressed mood or loss of interest or pleasure lasting at least 2 weeks, plus 4 of the following symptoms, which might be weight loss, insomnia or inability to sleep, changes in their activity, they're severely agitated, decreased energy or fatigue, feeling of worthlessness or guilt. So if they have, or thoughts of suicide, decreased ability to concentrate, these are all potentially a severe major depressive disorder. There's a lot of women, it's estimated 14.5% of postpartum women have this. It has an effect on her partner, and other children within the family. Her inability to take care of herself or her baby puts her baby and herself at risk for safety issues. Some of the risk factors are history of depression before pregnancy or during pregnancy, previous postpartum depression, inadequate social support, poor quality relationship with her partner, life and child care stressors, complications of pregnancy, and it could be other things. I mean, these are just a few of the risk factors. Assessment findings are, they can't sleep well, their appetite is not good, fatigue all the time, they're sort of despondent, uncontrolled crying, anxiety, fear. We screen all postpartum women at their 6-week checkup or sooner if we see them, with a depression screening in the offices. So that's nice. That's good. There is the major difference between postpartum blues and postpartum depression are the postpartum blues usually disappear with no intervention. The postpartum depression continues and requires intervention. And then, there's a table 14-2 you can kind of take a look at for the differences of those. And I'll talk about postpartum psychosis in the next couple slides. So again, take a look at this table 14-2 with the differences between blues and depression. So for postpartum psychosis, it's a major psychiatric complication, and they even consider a variant of bipolar the most serious form of postpartum mood disorders. It is rare, 1 to 2 women per 1,000 births it happens to, and it does require immediate hospitalization and evaluation. The risk factors are women with known bipolar disorder, personality disorder, or bipolar. And then assessment findings, you'll find, oh boy, they'll be withdrawn, depressed, hostile, mood swings, extreme agitation, suspiciousness, confused thinking, really a lot of the stuff that we're going to talk about when we get to mental health, which is coming up. And we do talk about this again when we talk about some of the mental health disorders at some point. They do need to be hospitalized and have a psychiatric evaluation by a psychotherapist or a psychiatrist. They're usually put on antidepressants, sometimes antipsychotics, and put them through psychotherapy, group therapy, and if that does not work, electroconvulsive therapy. And monitoring these women who are at risk for this potentially to happen to them are the people that we need to think about when we're monitoring them in the hospital if they have any risk factors. Okay, so I finished all the slides. This is a case study on the next couple of slides. You can review that on your own.